Any other questions? Please. I'm taking a talking head. Anybody else? Anything from Stephanie?
So far, nothing from online.
Open online too. Type in the chat. We will answer them. This is a daunting disease. If you want to say there are worse diseases, this and Huntington's are about the worst. But let's talk briefly about, which we didn't put on here, seeing patients with cognitive impairment and a dual diagnosis. Very often you can get a dual diagnosis with ALS of FTLD, frontal temporal lobe dementia. Sometimes you'll have a triple diagnosis of ALS, Parkinson's, FTLD. So, with the frontal temporal lobe dementia, very often that's the first presentation. Very often I have 2 or 3 people that I've seen recently that the bizarre behavior starts first. The patient who never went to bars and drank before, never was disinhibited sexually before. These can be the first signs and symptoms. Very often they go to the neurobehavior group, the memory loss group. They're being evaluated in neuropsychiatry. Very often they're seen there and then sent to us. So this is very specific. It's not dementia of the Alzheimer's type. It's dementia of the ALS type. So you will see something. Sometimes you'll see patients with cognitive, just mild cognitive impairment of the type of decision-making, executive function disruption, decision-making, insight, judgment, that kind of thing. But it's not, again, it's not dementia of the Alzheimer's type or dementia of the vascular type or dementia of the Parkinson's type. There are so many different dementias. I just wanted to be sure because I didn't cover it. Has anybody seen patients with dementia and ALS? Yes.
I'm not sure.
Louder.
When we get the ALS, we're all just like, how are we going to help that patient? We can help with so many other issues of pain. So when we go into home, they're short of breath, they're full of anxiety. How am I going to approach that patient, the family, and everything? What am I going to do first to start the process and to help them?
Well, first of all, find out who their neurologist is. Okay, let's take a look. You could be getting this referral from a primary care physician.
No, I'm going in with that phone call from the family at home. And there's my
Are you sure that the patient has ALS?
they are our ALS patients.
Oh, they're your
They're
patient.
our
Okay.
ALS
Oh, okay, got it. Okay.
And so we go into the home and we have a panic or an irritable patient, and we have a family who's exhausted and tired of everything. So when I go into the home, what am I going to do to help them initially get that happen?
Okay, find out is the patient short of breath, if that's what's causing the anxiety. Are you using your BiPAP correctly? Are you using your Trilogy correctly? Do they have medications in the home for anxiety? Do they have medication in the home for anxiety? A few drops of lorazepam and putting the BiPAP mask on. If the settings are not achieving the outcome you hope for, be sure you call the respiratory therapist who's involved with it. So those there are things. And talking them through the anxiety, knowing you're there for them, that there's someone 24/7 at the other end of the phone to relieve the anxiety. But talking them through, just sitting there and understanding and saying, we need to help you, and let's see what we can do. Are you using the BiPAP? Why aren't you using it? It's not fitting correctly. Okay, let's get it fit correctly. We can do all of these. Someone doesn't have to really suffer, and maybe it's the loved one who needs an anti-anxiety medication. Why is she or he's stressed out because she needs rest, because she's overloaded, because she's overwhelmed. She can't do it anymore. Why haven't you hired private caregivers? They really can't afford the private caregivers. This is a patient of ours from West Turner or Northwestern. We have grants available for respite to help get care in the home. Maybe something as simple as that. If the wife or the caregiver or the loved one is just so anxiety-ridden they can't do it anymore, that they're triggering the anxiety.
Mm-hmm. Your social workers help caregivers?
Yes.
Caregivers who are specifically able to...
Yes. Yes, we have a list. We have some agencies we work with. We have a list. An agency is not an agency. Okay. No, you need someone who's had it. Yeah, we have private and we have agencies. And then again, we have grants. We have grants for respite. We have grants for equipment. We have a loaner pool of equipment for both speech-generating devices, for power wheelchairs. Say someone comes to you and they've declined a power wheelchair. Oh, I'm not going to need a power wheelchair. Okay, so now they're in hospice. $20,000, $30,000 piece of a power wheelchair. You're not going to supply that. Oh, it's a loaner. So something as simple as that.
So the question is, they do have to West Turner and not just the ALS Foundation.
Correct. Yes, correct. They have supposedly, I can't speak for them, but they are supposedly have a loaner pool when they have grants or stuff. We also have the transportation grant to get them to and from clinic. It's not to get them to the shopping center. It's to get them to and from clinic.
Or speaking of clinic, if you do have a patient that just does not want to do that big trip to clinic anymore, okay, just because they're not going to clinic does not mean that the pulmonologist and neurologist are going to just sign off on their care.
We follow them to the
Like, with their bypass, I work very closely with Dr. Wolf and Dr. Coleman. I'm still going to download their machines. It's still going to go over to pulmonary. We're still going to discuss if these settings are okay or if there need to be any changes on the unit, on the breathing therapy.
And then we also do joint visits.
Mm-hmm.
Sherry and myself and the other 4 nurses, we do joint visits with you. We don't leave the patient unless they want us out of it. Not usually the way. Yes.
So, when you think about all of your friends, I have 2 questions. How many of your patients, do they all eventually go to hospice? That's one question.
No, they don't all because some choose to go on.
And what do you find is the most frequent way that they
Respiratory failure. But
I guess I'm asking because we just had 2 patients on our team that we saw hours before, and then we found out the next day they suddenly died. So do you put that under, I'm assuming maybe it was CO2 narcosis?
no, most likely a mucus plug. Also. Or a CE. There are many ways they can come. And sometimes they choose to go through Dextron, palliative sedation. One of I've done 1 or 2 with you, 2 with them. Yeah, recently we've had at least 3, 4. Sometimes they choose. They've been on a. It can go either way. They've been on a tracing event, then they've done it for 3 or 4 years. They're going bankrupt. This is a very expensive disease, financial bankruptcy. So they're on events, they want to come off. That's one way to do it with one reason for palliative sedation. Other, someone recently at Glenview, the patient I've seen for 22 years. She's now 84, she was 84. She was decisional, confident.
Like Ileane said too, with respiratory, I had a recent patient, we actually were speaking of the same one, where, he refused to wear his mask during the day. He wouldn't be on that bypass during the day, so we could have been increasing the CO2 levels every morning, all day long, and then trying to blow it off throughout the night. Just to see, if they were doing their therapy, were they doing the cobalt test, was it a mucus plug that actually caused that final?
With some of the patients that we had, maybe they weren't all part of your program, but they don't have all this equipment because
dies in a much more animal way. More than that always.
I think I said, you guys, just so you know, and I tell my patients all the time, they'll ask me, is there such thing as wearing this too much? Can I get addicted to my mask? Okay, for your bypass? Absolutely not. If you're more comfortable with your mask on, wear it. Don't let your patient be air hungry. That is one of the worst feelings in the world. I mean, one of the things I'll do with my family members is for a minute, I'll time it. I want you to breathe very shallow. Little tiny breath, just breathe very shallow. After 15 seconds, are you starting to feel a little like you need to take a big breath in? Just imagine breathing like that all the time. You know, again, this mask, all it's doing is giving them a little relief. We don't have that air hunger.
This is not keeping them alive. It's giving them quality.
You know, a very common problem with saying that they always feel like the tongue is too long, or feel like it's in their mouth, or
Dry mouth. It's usually dry mouth. It's usually dry mouth. Or atrophy of the tongue. The tongue is atrophy. The tongue is swollen. And especially with the bulbar patient.
so how do you work around that? Because I've had one patient that kept on chewing on his tongue and it was massive.
Okay, so yeah, that can happen too. And clonus and so on. So the lorazepam works for that. Just like it works for the laryngospasm, drop by drop in the buccal mucosa on the lorazepam to stop it. Sometimes they clamp down if you're suctioning. They can't help it. They clamp down. Usually lorazepam to get that.
Very young patient. He wasn't even on oxygen. He wasn't even on bypass. It's pretty high functioning at this point. And he was asking if he could put his hockey guard and get out the second.
The lorazepam will help relax those muscles and the tongue atrophy is one of the causes for also aspiration because they can't get the bolus of food around. That's all to that. That's it.
29. Anybody have one? I actually do. So maybe with the ALS Foundation and the left term, I'm either one or the other.
One or the other.
So my patients are in that way.
If they're going to the ALS Foundation's clinics, like UC, UVI, etc., Rush, they are with the ALS Foundation. They have nurses. All right. Thank you.
Thank you.
That was good.
Everybody,
Wonderful. Thank you so much.
And so today was a CE credit, so we didn't say at the beginning, we have no biases. They're here for educational purposes, right? You're not biased in any way. We just want to help people with ALS. We just have to. So we're going to send you all a Survey Monkey for you all to fill out for getting a CE credit. Don't forget to get your CE certificate on the way out and make sure that you sign in to get credit for coming. Right, y'all want credit for that?
That's it.
And also, Stephanie does have the PowerPoint presentations on the respiratory end. It has the Cuff Assist presentation, the breath stacking presentation, and also a couple of YouTube links.
Yeah.
So you can watch that on your breath stacking.
Does everybody want those? If you all want it, then I'll send it when I send the survey link so that everybody can have that. Yeah, to see what I'm running into a problem. Still be helpful.
And I am, my card's in the back too. I'm always a phone call away. If you guys have any questions.
Right.
No. And my card is back there.
And let her know that what I am. I just be here to help. Yeah, and to orient that person. Nobody else. Yeah. You want for,
Let me, yeah, let me go talk to you.